Hi, thank you for coming today to listen to my talk. So I'm going to be talking about preterm birth and fetal fibronectin. So firstly, a little bit about me. My name's Naomi, and as it was just mentioned, I work at King's College London in the joint department with St Thomas's Hospital. So it's quite a special department. It's a clinical academic unit, which means that we do research which is based on the most clinical important questions. And I work in a team which is led by Professor Shannon, who's a world expert in preterm birth prediction and prevention. And this talk which I'm giving you today is everything that I've learned since sort of working in his team and everything which I wish I knew before sort of starting and being a specialist in preterm birth. So firstly, the problem of preterm birth. As a lot of you probably already know, preterm birth is delivery before 37 weeks of pregnancy. It can be either spontaneous, so when a woman goes into labour spontaneously, she might start having contractions, her waters might have gone, or it can be iatrogenic, so when a woman has an elective caesarean section or an induction of labour for a medical reason like preeclampsia. Preterm birth can also be divided into 3 distinct categories dependent on the woman's gestation. And I also just want to mention here second trimester or late miscarriages. So these are miscarriages which occur in the second trimester, and they're quite important because more evidence is suggesting that the mechanism for late miscarriages and preterm birth is actually very similar, and the only difference between them is the gestational age of viability. So when you're thinking about preterm birth, it's worth having these late miscarriages in the back of your mind as well. So currently in the UK, our preterm birth rate is around about 8%, and if we compare that to the rest of Europe, you can see that we don't have the highest rate, which is Austria, just over 11%. We don't have the lowest rate, which is Finland, at 5.9%, but we definitely are at the upper end. And the reason that this is important to look at it with what the rest of Europe is doing is because last year, our then Health Secretary, Jeremy Hunt, pledged to reduce preterm birth to 60% by 2025. So it's an issue which really needs a lot of attention to try and help us get that rate back down. So if we now look at the causes and risk factors for preterm birth, the ones that we know about, so we've got medical risk factors. So for example, if a woman has an infection, we know that that can cause preterm birth. Obstetric risk factors, so for example, if a woman has had a previous preterm birth or previous late miscarriage, she's at a very high risk of having her next baby early. There's also emerging evidence about women who have had a full dilatation caesarean section. This is very new evidence, but what we're seeing is that women who have had a full dilatation caesarean section are more likely to have their baby early in their next pregnancy. And the reason for that is it's thought that when women are having a caesarean section at full dilatation, obstetricians are actually cutting into the cervix rather than the uterine cavity, which is causing damage to the cervix and weakening it, which therefore means that they're at an increased risk in their next pregnancy. Gynecological risk factors, so for example, if you have an abnormal smear test and then you have a LETS procedure, that removal of the cervix means that you're more likely to have a preterm birth in the next pregnancy. Uterine distensions, if you're carrying twins or triplets. Lifestyle and behavioural factors, so we know that women who smoke, women who are victims of domestic violence, women who have high levels of stress, all of these things are all associated with having your baby early. And lastly, socio-demographic factors, so for example, race and ethnicity, especially in the USA, but even in the UK, we know that women of particular ethnicities are more likely to have a preterm birth compared to women who are considered to be white, white British, white American, and this is obviously a disparity which needs urgent attention. But most confusing of all, most women don't have any risk factors. So we know that more than 50% of women who do deliver preterm don't have any identifiable risk factors. And we know that approximately 2/3 of women with traditional risk factors don't actually go on to deliver preterm. So as clinicians, how can we determine who will have their baby early? So I just want to talk about one case study first of all. This is a symptomatic woman. So meet Lily. It's her first baby. She's 29 weeks pregnant and she arrives at your unit at 2 a.m. in the morning, because these things always seem to happen at 2 a.m. And she's come to you with abdo pain. She's got no SHROM, no PV bleeding. It's a very low risk pregnancy apart from this admission, and she says that her baby's moving well. So you triage her and everything seems completely normal. She is contracting, but irregularly, and it's approximately 1 in 10 on palpation. It does feel quite mild. So with her consent, you undertake a speculum examination and her os is closed. So what do you do with Lily? Is she in preterm labour? You don't want to be the person who sends her home and then she ends up having her baby early. But then also you don't want to admit her and then her still to be sitting there a week later and her bed blocking. And threatened preterm labour is a real challenge for clinicians. So threatened preterm labour is defined as women who are arriving with symptoms of threatened preterm labour, so abdominal pain, that sort of thing, but there is no cervical change. And we know that 70% of women who arrive with these symptoms, like Lily, actually give birth at term. So it's not that they give birth in the next few days, they're actually giving birth at term. And we know that if we admitted every single woman like Lily who arrived with symptoms of preterm labour, a week later, more than 95% of them would still be sitting there, still not delivered. So if we go back to Lily and we're thinking about what we should do with her, it would be really helpful if we were able to do a predictive test, which would help to sort of guide our clinical management and help us decide a clinical management plan for her. So let's move on to the predictive tests that we have available for preterm labour. So here are some of the tests, and I'm sure you're probably familiar with at least a few of them. So firstly, we have transvaginal ultrasound cervical length measurements. So this is an ultrasound scan which is done transvaginally and it measures the woman's cervical length. And then we also have biochemical markers. So the three which are available in the UK at the moment are actin partus, partasure, and fetal fibronectin. And here in Scotland, I think the majority of you use fetal fibronectin. And fetal fibronectin is the one that I'm going to focus on today, mainly because the majority of you are using it, but also more importantly is that it's the only one which is mentioned in the current NICE preterm birth guidance, which was published in 2015, but also in the more updated biomarker test guidance, which was published earlier this year in July. So for those of you who don't use fetal fibronectin, let's go right back to the beginning. So fetal fibronectin is a glue, that's the best way to sort of think of it, a biological glue which holds together the fetal membranes and the maternal membranes. And it should therefore be kept in that uterine cavity, so you shouldn't be able to detect it in that vaginal area unless perhaps something is happening. So for example, a woman has some sort of breakage or leakage or something perhaps is going on, which means that these fetal fibronectin secretions are trickling down into the vagina. So we know that if we undertake a vaginal swab test on a woman between 22 weeks until 36 weeks of pregnancy, and we can detect some fetal fibronectin there, it means that this woman is more likely to be having her baby early. So what makes a good test? So we're looking at all these predictive tests in labour, but how do we know if they're actually a good test to use or not? Well, there's two things which mean that a test is a good one. Firstly, it's a good predictive test. So this means that it has a high positive predictive value. So that means that if your subject has a positive screening test, what is the probability that she really will deliver her baby early? And that's really good because it helps us guide interventions. So it helps tell us which women should we be admitting to hospital, which women should we be giving steroids to, that sort of thing. Another good aspect of a test is if it's a good rule-out test. So that means it has a high negative predictive value. So this means that if a test subject has a negative screening test, what is the probability that she really won't deliver early? And this is important because it's confidently used to discharge women home. So we know that if they have a negative test, we can send them home, be quite confident that they're not going to have their baby early. So we look at fetal fibronectin and the positives and negatives which it has. One of its weaknesses is that it has a low positive predictive value. However, this does improve quite significantly with quantitative fetal fibronectin, which I'll talk about in more detail in a couple of slides' time. Fetal fibronectin has a lot of strengths. It's the only clinical biomarker test recommended by NICE. It's a truly objective test, so you're getting a result from a machine, so it's not based on your judgment, it's a truly objective test. It's a really good rule-out test, so it means you can confidently discharge women home. Has improved positive predictive value compared to clinical assessment alone. And lastly, it can produce a result in 10 minutes, so it really is a bedside test. So how do you take a fetal fibronectin sample? So firstly, you need to undertake the sample using a speculum examination, and you are using a cotton buffer tip, which you can see there in the collection kit, and you're taking a swab from the posterior fornix of the vagina for 10 seconds. Then you remove the swab and you insert it into the buffer solution. You can see that middle tube there. And then once you put the cap on that buffer solution, that test there can be kept in room temperature for 8 hours, and it will still produce a clinically sufficient test. So that's a really important bit of information because there's no charge for these collection kits. All you're paying for is when you analyse that test through the machine. So If you have a woman who arrives in your unit and you're not really sure if you should be running the test or not, you don't want to spend that money on your hospital, you want to be really sure that it's worth sort of spending the money on her before you undertake that test. The fact that you know these collection kits are free, it means that you can take one of these tests, discuss it with your colleagues, talk to your senior midwives, talk to your obstetric colleagues, and if you then think that it is worth running this test on this woman, you think that she potentially may be in threatened preterm labour, you can then run it, and you can run it up to 8 hours after you've taken that initial swab. So that gives you a really big window for you to discuss that clinical care plan with your colleagues to decide what the best thing to do with her is. It's also important to mention that when you take a fetal fibronectin swab, you need to do it before you undertake a digital examination. So it's therefore a really good idea if you have a woman where you think that you might want to take a fetal fibronectin swab, that you do take one of these swabs at the very beginning when you're first assessing her, before you do a vaginal examination, before you insert a vaginal probe, anything which could give you a false positive result. And as I said before, you've got those 8 hours to then decide whether you want to run the test or not. I also just want to mention briefly recent sexual intercourse and spotting, which some of you may have previously been told that these can give you a false positive result and therefore not to take a fetal fibronectin swab. You're right, they can give a false positive result, but the new evidence is saying that if you have a woman who has had recent sexual intercourse or has some spotting or light bleeding, you can still take a fetal fibronectin swab, and if the result comes back as a very low negative, so under 10 nanograms per milliliter, that still counts as a true negative. If the result is high, then you can obviously decide what to do with that. But I think that's really useful when you have a woman who comes in. If you run that test on her and the result is a true negative, then it means that you can still confidently discharge her home despite the fact that she may have had recent sexual intercourse. So you've got your swab test, you've discussed it with your colleagues, you've decided to run it through the analyzer machine. So you run it through the machine, and in 10 minutes you'll have a result, and it will either tell you that the result is negative or positive if you're using one of the old qualitative machines. And negative and positive basically means that the result is either under 50 nanograms per milliliter or it's over 50 nanograms per milliliter. But there are some new tests which are now out, and I'm sure some of you are probably using them already, which instead of just telling you negative or positive, they're telling you the actual concentration of fetal fibronectin. So these results are called quantitative results rather than qualitative results. And the quantitative results give you a fetal fibronectin result from 0 to 500 nanograms per milliliter. And you're probably thinking, why is it important that I know the actual result? Well, this paper here was published in 2015, and it was looking at asymptomatic high-risk women, and they compared quantitative fetal fibronectin with qualitative fetal fibronectin. And what they found is then women who were previously classified as having a positive fetal fibronectin result, so this is anything over 50 nanograms per milliliter, if your result was on the higher end of that, so it was over 200 nanograms per milliliter compared to 50 to 199, you were 2.5 times more likely to have a spontaneous preterm birth. So this tells us that rather than just treating anyone who's got a positive result over 50 the same, we really should be looking at that exact concentration of fetal fibronectin to help us guide management, because this is telling us the higher the woman's fetal fibronectin result, the more likely she is to be having a preterm baby. It also looked at negative qualitative results. So previously this was anything under 50 nanograms per milliliter. And this study showed us that if you have a woman that has a very low negative result, so anything under 10 nanograms per milliliter, her risk is actually the same of giving birth preterm as the general UK obstetric population. So that's really reassuring for a woman who has a risk factor of preterm birth. If you undertake a fetal fibronectin swab on her and it comes back as under 10, you can say to her, not just that your result is negative, but you can say to her, your result is the same as any woman who's likely to give birth early in the UK, not just women who have a high risk factor like yourself. And that's really reassuring for women to hear. So if we go back to our first case study, Lily, so you remember it was 2 a.m. and she had arrived with some abdominal pain. She was 29 weeks and it was her first baby. So if we undertook a predictive test on Lily, it's 2 a.m, so we're unable to undertake a cervical length scan. There's no one available in the unit who can undertake one, but we can do a fetal fibronectin swab. So we do one and we get a positive result, and it's 290, so it's quite a high positive result. Lily then tells us that she lives in a rural area. It takes her 45 minutes to get to the hospital. So with all of this information now, and now that we've got this fetal fibronectin swab, Probably the best thing to do in this scenario would be to admit Lily, and then perhaps in the morning see if we could undertake a cervical length scan if one's available, and then we could sort of work out a further management plan then. But I think especially given the fact that her result is high, we know that it's quite a high positive result being at 290, and the fact that she lives quite a while away, it would be a good idea to admit this woman. And fetal fibronectin can also be used in asymptomatic high-risk women. And I know that here in Scotland, quite a lot of you are using it on symptomatic women like Lily, but you're not using it as often in asymptomatic high-risk women. So asymptomatic high-risk women are women who currently don't have any symptoms of preterm labour, so they don't have any abdominal pain, but they have a risk factor, which means that they're more likely to have their baby earlier. So if you remember one of the first slides I showed you of all the risk factors for preterm birth, they've got one of those tick boxes, which means that they're more likely to be at risk. So meet Sally, it's her second baby. She's 28 weeks and she had a previous preterm delivery at 29 weeks gestation. And Sally is absolutely petrified that she's going to have another preterm baby. So she's come to the antenatal clinic for her 28-week check, and you undertake it and it's all completely normal, baby's moving well. But Sally is a little bit worried because she's meant to be going on a business trip in 2 days' time to Manchester, and she doesn't know whether she should go or not, because obviously then she'll be 28 plus 2. She lost her last baby at 29 weeks. And she's sort of asking, you know, do you think I should go or not? And as a clinician, that can be quite hard to answer those questions. And this is where predictive testing can be really helpful to help you guide a woman's management plan. So if we look at Sally, and if we undertake a predictive test on her, it's in the daytime. We are able to undertake a cervical length scan. The scanning machine's open and we've got people who can use them. And we undertake one and her cervical length is nice and long, it's normal. And we can also undertake a fetal fibronectin swab, and we do, and it comes back negative, and a really low negative. It's under 10 nanograms per milliliter, it's come back as 5. So with this information, we could then say to Sally, you are at really low risk of having your baby imminently. So you can go on your business trip to Manchester, but take your hospital notes with you, make sure you know where the nearest unit is when you're there, and perhaps arrange another antenatal appointment with her maybe in a week or maybe in 2 weeks' time, and then when she comes back, we can repeat these tests again and then see what they say then, and then work on a sort of a week-by-week basis to plan her antenatal care. And this means that we're planning really individualised care for this woman, and we're pinpointing exactly to be what she needs and what her risk is, rather than just doing a blanket approach. I also just want to talk very quickly about the QUIPP app. So the QUIPP app is quite a cool app. It was developed in the department where I currently work, so at St Thomas's and King's College London, and it's free to download, so you can download it for free on your iPhone, on Android, and you can also get an online version. So if you go on quippapp.com, it will take you to a link where you get like an online version of the calculator. And this is a validated app, it's CE marked, and it gives you an individualised risk score for women, whether they're going to have their baby early or not. And you can use it on symptomatic women and asymptomatic women, and it's, the data involved in this has been over 2,000 women, so it's a really large sample size and it has been clinically validated. So here are the two interfaces of it for symptomatic and asymptomatic. You know which side of it you're using because the colours are obviously different, but also again at the bottom you can see that you can switch between the two with symptomatic, asymptomatic and the information section. And I just want to run through a case study with you. So if we go through our second case study, so that was Sally, the asymptomatic high-risk woman. So it's really, really simple to use. You just go through all of the questions. So previous cervical surgery, no. Previous preterm birth, yes. We know that she had a previous preterm birth at 29 weeks. No previous prom, no previous late miscarriage. We can use it on singletons and twins, and Sally's obviously carrying one baby, so we've got one baby there. We know that she's 28 weeks exactly today. We do have her cervical length measurement, which we know is 32, but if you didn't have the cervical length measurement, you can leave that section completely blank and the app will still give you a result, and her fetal fibronectin result, which was obviously 5, and then we press calculate. And what it tells us is this woman's risk of having a early baby for 30 weeks, 34 weeks, 37 weeks, and within 1 week, 2 weeks, and 4 weeks. And this is really useful for clinicians because it's a real individualised risk score that we're getting for this woman. It's taken into account her medical factors, but also her clinical results from today. So we know this is a really accurate result to use. And one of the most important results for you to use as clinicians will probably be the results which tell you her risk of having a baby within 1 week. And that's because it's the nearest time frame, and it's when you're looking at women and you're deciding whether to admit them or not, or whether to send them home, that's the sort of information that you want to be looking at. What's their imminent risk of delivery? So for Sally, we know that her imminent risk of delivery within the next week is 0.3%, so it's really, really low. But we know that if we look at before 37 weeks, her risk of having an early baby is 8%. So that is, probably higher than it would be for a woman who didn't have her risk factors. So this is a real, true example of where we can use this test to say you don't need to be admitted imminently. You don't need steroids, you don't need an in utero transfer, any of those things. But it does tell us that looking forward, this is something where we could look at your antenatal management plan and decide when to bring you back for further treatment, for further testing, that sort of thing. And I think this sort of individualised risk planning or individualised antenatal care is becoming more and more important, because a lot of us already know about the risks of having multiple courses of antenatal steroids. So now it's recommended that women only have 1 course of antenatal steroids. We don't give multiple courses of antenatal steroids, and that's because we found all these adverse effects with neonatal outcomes. So this means that we can't be admitting every single woman when we think that she might potentially have a preterm baby and giving them all of this additional treatment, giving them all of these steroids. We really need to be admitting women who are only likely to be having an imminent delivery and giving them that treatment then. And this is a really good way of making sure that we're not over-medicalising those women, which obviously has benefits for the woman, but also for us in terms of cost saving and terms of ward management. So thank you so much for listening. I know that was a bit of a whistle-stop tour. I'm happy to take some questions now, but also there is a stand in the main foyer where her logic is currently, and they can ask you specific questions about fetal fibronectin as well. Thanks.